Mr. Yip Hon Wing.
Thank the SMS for clarity about the COVID situation in Singapore in his ministerial statement. Given that seniors, especially those who are not vaccinated, are most susceptible to severe illnesses due to COVID, can there be initiatives to identify, isolate and protect these seniors? And thus, if we can implement such measures to protect seniors in an effective way, is the ministry prepared to consider loosening safe management measures for the rest of the population? Thank you.
So I thank the member for the question. In a way, that is what we are trying to do with our vaccine differentiated measures. Expose some people to a lower level of risk while allowing other parts of our population to do the things that make life a bit more bearable. But there's only so far that we can go, you know. If you're a senior and you're unwell, and for some reason unvaccinated, you can't be locked up and isolated completely. You need fresh air, food, contact with other people. So I understand what the member is asking. The question is, how far can we go? And we don't think we can go much further than where we are today. Vaccine differentiated measures. But there is another dimension to this question, because it supposes that the seniors and the vulnerable are a different population from the rest of us, who are younger and healthier, vaccinated. And the truth is, we interact and we meet, and we pass infections on to them. I think the experience of the last 2 years, in a way, has demonstrated just how much intermingling and interconnectedness there is between all kinds of networks and communities here in Singapore. It's part of our human response. Our grandparents want to see their grandkids. We want to go and look after our parents. And each of those interactions poses a very small but measurable risk to them as well. And so I think we have to assume that whatever it is we're doing, we must treat the whole population as one. We will try with the vaccine differentiated measures, but there's only so far that we can go.
Dr. Lim Wee Kiat.
Thank you, Mr. Speaker. I would like to raise two SQ. Let me thank the SMS for the statement just now. First SQ is about whether can we make vaccination mandatory. Since that the vaccine now has been fully approved by FDA, I filed a PQ asking whether when will HSA makes the vaccine not used under emergency use, which means it can be fully licensed to use for normal times. That's the first SQ. Second SQ is regarding SMS observation about the immense stress and pressure of our healthcare workers and what they are shouldering, especially over the past few months. I would like to ask whether MOH will be planning for more support and recognition awards to healthcare workers given the amount of stress and the work they have shouldered during the pandemic. Thank you.
So, making COVID-19 vaccination compulsory is a significant move. It should be carefully considered. We do have to consider a number of factors: the vaccine coverage, international practice, and the availability and performance of fully registered COVID-19 vaccines. The introduction of the vaccine differentiated measures in a way is to try to get around some of that problem, to expose the two populations at different risk. But in terms of making a mandate compulsory, it is also quite difficult in terms of the execution. You can imagine that for something like childhood vaccines, you may say that you can't have access to playgroups or certain school environments and so forth. There's a specific thing that you need to do, that you want to do, and for that you're getting the vaccine. But really here we're talking about all the normal activities of life. And so policing it, executing it, implementing it is not without challenges, and the question is how much benefit will there be. So I think it's something to consider, but there are a whole lot of complications associated with that. So the Minister for Health has indicated he'll answer the second half of the question.
Thank you, Mr. Speaker. I thank Dr. Lim Wee Kiak for asking the question on recognition for healthcare workers. Many people contributed to this fight against COVID-19. We got the people who does all the swabs, supervise our self-swabs, the people who run our vaccination centers, people who make sure the vaccines arrive on Singapore shores, people who does conveyancing every day, hundreds, thousands of trips to and fro hospitals to treatment facilities, all our officers on the ground, safe distancing ambassadors, our vendors who disinfect places that we've been to, teachers who kept schools going for the past 20 months, preschool teachers including, social workers, our community volunteers who help out to those who are in need. We all owe a debt of gratitude to all of them for collectively putting up this fight. But as SMS Janil has very vividly and in a very heartfelt way described, I think the role of healthcare workers is especially important. They are not just like the other frontliners. They are also our last line of defense. So while the rest of Singapore, we try to get back to normal life, try to get back to work, to travel for work or study, they bear that disproportionate responsibility. That if something goes wrong, they are the one who carry the burden and literally the last line of defense, while the rest of us can continue our work. So I know that monetary award is not everything, but I think it's probably appropriate, probably the least we can do to recognize their commitment, their dedication, and all the physical, mental, emotional stress that they are going through. So thank you for that suggestion. It's something that we are seriously looking into.
Leader of Opposition.
Thank you, Mr. Speaker, and thank you to SMS for the statement on ICU capacity. I'd like to refer to a report which is found on the Sing Health website. It really is it's carrying a Straits Times article on ICU capacity. This is dated 13th of August, and I think this number has been quoted by individuals online as well, when Health Minister said that up to 1,000 ICU beds can be made available for critically ill COVID-19 patients if needed. I think what the number suggests and what the numbers we have now insofar as ICU capacity is concerned is that there is yet sufficient potential for upscaling the number of ICU beds. Of course, the assumption being that this remark that is quoted on the 13th of August refers both to the bed itself, the ancillary equipment needed, and the manpower needed to manage the number of 1,000 beds. So I would just like to ask a question pertaining to this number. Is this still the operating parameter, or has things changed quite significantly? The second point is somewhat connected, but it is with regard to the measures introduced vis-à-vis the stabilization phase. I think there has been some pushback in terms of retaining the number of 2 individuals in a dining capacity. There is significant public feedback that this should be increased to 5, especially for vaccinated individuals, particularly since the government is also opening up more VTLs and lifting travel bans, or at least I think for the South Asian a group of countries, this was lifted very recently. So there's a view that that can't quite connect why this cannot be opened up in view of the number of vaccinated individuals who actually are not imposing on the ICU capacity as much as non-vaccinated individuals. So I hope there could be some clarity provided insofar as what is holding the government back on this number, on opening up at least on dining for up to 5 individuals. My third question really is, and this is the last one, Mr. Speaker, follows up on the numbers SMS shared with regard to the resignations in the healthcare system, 1,500 for the first half of 2021, and 500, and I believe an additional 500 were foreign healthcare professionals. Can I just confirm what has been the recruitment numbers over the same period? Minister SMS suggested that, not suggested, SMS said in his statement that recruitment of healthcare workers from overseas is continuing. So it'll be helpful to have the numbers that are coming on board as well, and not just the numbers that are leaving. Thank you.
I'll take the first two questions, and maybe SMS Janil can also comment on the first question and answer the third. I remember quite vividly that we talked about the possibility of ramping up to 1,000 beds. And I spoke about it at a press conference, illustrating how, if cases double every week, how in 5 weeks it's actually exhausted. And it's an illustration that even with that kind of capacity, if infections run away from us, it's no use. We just get overwhelmed in a matter of weeks. And I also remember vividly that don't even get near that. Don't even get near that. Not even near the 1,000 limit. SMS Janil is a lot more experienced in this, and he knows it inside out. And I think he had explained that we have all the logistics and all the consumables to set it up, but I think manpower will be a serious constraint. Can they handle 1,000 ICUs? I think not without a major degradation of care. Yeah. So I think it's not a black and white kind of situation. With every step up, there is a degradation of care, and there is a trade-off. The second question on whether we can increase dining to 5 for vaccinated diners, we wish to get there too. We were there before. We were even at 8 at one point. It is important to the F&B industry. It's important to Singaporeans. It's important for families to get together. But I think the time is not yet. I think we will get there. We will get there. The time is not yet. Because when you meet with 5, as explained by SMS Janil, you do increase the risk of transmission. But if it's transmission within vaccinated individuals, it may not be that serious. But we also live with older people, with seniors who may be unvaccinated, and we can inadvertently bring the virus to them. I have a neighbor, unvaccinated senior, and she has streams of visitors coming to visit her, persuading her to get vaccinated. So I was persuading their visitors, maybe stop coming to persuade her, just give her a call. But this is life. This is life in Singapore. So we do have to pay attention to that. There's always a comparison with why is it that VTL can open? We can open for travel, but not for dining. The difference is this, that in the initial stage, Singapore has very low infections, and around us and around the world have very high infection rates. So when you open up borders at that time, you are letting in the floodgates. You're opening up the floodgates. Today, the situation is entirely different. Our infection rates and the outside infection rates are similar, and in fact, they may be lower than us because they went through huge waves, and we are still going through ours. And furthermore, we limit travel or SHN-free travel to only vaccinated individuals, and at the border, you are subject to tests. Yeah. So theoretically, if you can have an event like a wedding, a bigger wedding, everybody subject to tests, you can sit in 5. So it is actually a similar concept. So I think this also presents possibilities for us to think about in future, for the MTF to think about whether through tests, through vaccination, we can allow gatherings that is a bit more free. And these are all possibilities that we'll continue to think about.
So I don't have the specific numbers of recruitment figures for the different clusters and organizations. We can get them. But I think one of the challenges we have to appreciate is that even if we recruit from overseas, anybody coming into that environment is new. They're inexperienced. By definition, they're inexperienced with the environment, our healthcare protocols, but they may actually be literally new in terms of their training as well. So their role is going to be quite different. It's going to be about augmenting manpower where perhaps that level of acuity and that level of complexity does not exist. So while we are recruiting, and we have been actively, and I will get the numbers, operationally, I can't see that that is going to make a huge difference in the ICUs. It will make a difference in other parts of our ecosystem. We hope that can displace a little bit of the manpower into some of the high acuity areas and then release a few people to go and help in the ICU. But I think this is a bit more of a medium-term strategy rather than something that we can rely on as an urgent fix to our current problem. If I may make a comment on the first part that the Minister of Health talked about, some of the uncertainty is about how long we have to carry a certain load or a certain number of patients within the ICU. I mean, if you have a terrible disaster, a mass casualty, some kind of very bad accident, you may have many times the number of patients than we currently have in the ICU. But that's a one-off incident. The patients won't stay as long. What we have today, it's the equivalent of a low-intensity conflict, and having to be on readiness and high alert for weeks and weeks and months. And your surge capacity at the start of a low-intensity conflict is very, very different after 2 years, or after 1 month. And even this current surge, when it started, there was really no way to know or model how long it was going to last and what the peak of peaks would be. So what Minister talked about is the logistical planning parameter. If you don't have 1,000 bed spaces, you know that you can't get there. But if you do, that's physically where you can locate people. But you need the equipment, and thankfully, as a system over the last 2 years, but it started long before the last 2 years, through emergency planning and resilience preparedness, we actually have the stocks of equipment that we need, the consumables, the little parts to drive the machines, as well as the drugs, in order to cater for many, many more patients than we have today. So as that colleague of mine said, we are not resource constrained at the moment. The manpower issue is not something that we can do a simple calculation. As I said, it depends on how long this goes on for, how long the peak goes on for, and crucially, today, coming to the end of 2021, the amount that we can reduce business as usual is really quite different from where we were, let's say, 6 months ago, and in fact, where we were even 3 months ago. Because that is an additional factor that we have to take into account. So the number is something that we have to think about in a fairly dynamic way.
Mr. Lim Beltran.
I just want to thank the SMS for his reply. So I'm just concerned that over the past week, the number of deaths has been in the double digit. So we've got 13 yesterday, 14 the day before, 16, 15, 10, as compared to end of September, where the deaths are 2, 3, 4. So can SMS explain why has the number of deaths increased by such a large number? Is it due to the relaxation of rules? Is there anything else we can do to cut down the number of deaths? Because really every life lost is a tragedy. Thank you.
So I thank the member for his question. Why are deaths rising? The proportion of deaths hasn't changed. Of people who get COVID-19, the risk of dying, the proportion of them who go on to need the ICU and then subsequently succumb actually hasn't changed. There are two major reasons why we are starting to see the absolute total numbers rise now. One is that the base of the base number of our population that let me say that again. The first is that the base number of our population that is being infected with COVID-19 has risen very, very significantly compared to the time period that he was talking about. The second is that some patients with COVID-19 who pass on will pass on very soon after getting the infection. But actually most will not only take a long time to get seriously ill, may take some time before they succumb, which is a testament to the care that we have put in place and their attempts to fight the infection. So there is a lag. The deaths that we're seeing now are not necessarily the same people who are being infected this week. They are people who are infected perhaps 2 weeks ago, maybe even a month ago, because it takes time. After you get the infection, it takes time before you develop a need to go onto oxygen. And then once you're on oxygen, not everybody will go on to the ICU or succumb, but it takes time for conditions to worsen to the point where then you need further care. So there are two main reasons why the deaths are rising in total number. Baseline has increased, and it's that effect of the lag. But I stress the proportion of patients who then succumb has not changed. Has not changed. How to prevent the deaths? Well, vaccinations, as I've explained, booster jabs, as I've explained. But even if you have had those, you may have other underlying illnesses. And the underlying illnesses need to be well controlled. And so if you have diabetes, control your diabetes well. If you are requiring medication, take your medication regularly. Comply with all the usual prescriptions around maintaining good health. And for those of us that are fortunate not to have health problems, well, you know, all the usual rules apply. Eat better, sleep better, get more exercise, and reach out to your loved ones. And if you're a smoker, stop smoking. You've got a lung infection with COVID-19 and you've knocked out some of your functions through smoking, you're not off to a good start. These are the ways in which we can prevent mortality and morbidity in COVID-19. Thank you, sir.
Associate Professor Jamus Lim.
Thank you, Speaker, and thank you, SMS Janil, for a comprehensive explanation. Like him, I am very much grateful for the efforts that our healthcare workers and frontline workers have had. I have two questions to follow up on preempting infrastructure. One has to do with ICU beds, and I would note that just before this discussion about increasing COVID coverage to 1,000 ICU beds, our ICU beds per 1,000 population was about 6. This is half that of the OECD average, and only Japan, among those that have a lower ICU beds per 100,000 of the population, has a significantly larger elderly share of the population. So the question here is, if we know that, as we did in the earlier half of this year, that we were going into an endemic surge, why is it that during this lull period there wasn't a more concerted effort in increasing our capacity? And this, of course, includes bringing in relevant manpower, which, as SMS Janil mentioned, was the big challenge. And my second question builds on this issue of manpower. Given the global nurse shortage, the WHO actually estimates by 2030 there'll be 9 million needed worldwide and 370,000 just for the US. My question is whether, looking forward, Singapore will be competitive in attracting these foreign nurses, and if not, what steps are being made to expand our local nursing workforce and doctor workforce to ensure that we are able to meet our future needs?
So I thank Professor Lim for the question. So as I'd explained, pre-COVID, peacetime, we had about 300 ICU beds for the country, 298. And the average occupancy was about 63%. So it's not that we didn't have spare capacity pre-COVID. But as I've already also explained, if you wanted to open up more of this capacity and keep it empty, it would have an impact on resources that could have been applied elsewhere. So I don't know if that addresses his first question about why we didn't do more before we knew about COVID. I think comparing with other countries is fraught in this situation because the number does not reflect, for example, clinical practices, the demographics, in terms of the health patterns that they have. So I don't think one can take the view that there's a certain number of ICU beds that you must have per population. I think what we are most interested in is what the ICU system and the healthcare system is able to deliver in terms of outcomes, clinical outcomes. And I think if the member dove into those details, he would find that our clinical outcomes and our ICU outcomes are much more than comparable to any of those countries that he has listed, with perhaps less total beds per population. Some of this also rests on the fact that what counts as an ICU admission is quite different from country to country because of the way in which the nurses are licensed, the way in which drugs are licensed, the way in which doctors practice. He then asked about a more concerted effort to increase capacity. Well, it's not that we stood still, and waited to see what happened. We were indeed doing the cross-training, and as I explained, the cross-training and the cross-deployment of nurses, that was a concerted effort. The reduction in elective work to free up resources, that was a concerted effort during the lull. But the thing about ICU manpower, you cannot stand it up and have it lying around waiting. If a year ago we said we needed to increase our manpower by 3 times or by 4 times, what would those nurses have been doing in the ensuing 12 months or 6 months? They certainly wouldn't have been getting experience at ICU care because you need to look after ICU patients in order to become an ICU-trained staff. And so you can see that what we've been doing is opening up capacity ahead of the curve, not so far ahead of the curve that we are having people sit around idle while other services are undermanned or unmanned, but ahead of the curve so that we can do some of that training and redeployment. Intensive care, critical care, whether you talk about the doctors, the nurses, the respiratory therapists, the social workers, the pharmacists that are deployed in there, it's a clinical practice. It's not something that you can learn and be ready for by reading textbooks and doing online courses. You have to be mentored and precepted into looking after patients with your hands, with your eyes, with your senses. So it's not something that you could have gone 5x, 4x in vacuo in peacetime and held everything ready and in abeyance. It would have been a waste of resources, but it also would not have been effective in terms of changing the outcomes currently. I stress again that while the healthcare system is under stress and our healthcare workers are tired, they are delivering excellent outcomes. And I say this not as a matter of hyperbole, but that lowest mortality rate in the world is matched by any number of other patient care and clinical quality indicators, which I think we and our healthcare workers should be justifiably proud of. Thank you, sir.
Ms. Mariam Jaffa.
Janil for his explanations. I have an SQ related to bed capacity, ICU bed capacity. So SMS gave the data on ICU bed capacity and utilization for both COVID and non-COVID beds and clarifying the limiting factor, i.e. manpower. I had a question because and based on the data provided, you have currently, I think, 382 total ICU beds. And you also said that 163 non-COVID ICU beds are running at 80% utilization today, an increase from 63% pre-COVID. So I think my ICU really is, despite this increase, is this something that how do I benchmark 80%? Is it something that we're still being too conservative about? And part of that increase to 350 ICU beds will still be able to come from this pool? Or is it really something that we should be really quite concerned? Because if my math serves me right, 163% occupancy of 298 beds in 2019 means 188 non-COVID ICU beds being occupied versus 130 today. We are saying 80% of 163. So are we just putting less people in ICU today? And is there really no impact, no deterioration on patient outcomes? Thank you.
So I thank the member for her question. Maybe I can start with the last part first, which is no impact and no deterioration. Actually, I would say, firstly, there is an impact. And I think the statements and quotes from my professional colleagues, what I've described as the conditions under which they're working and their concerns for themselves, that is the impact. But there has not been a deterioration. That is the outcomes. So it is through their heroic efforts, their resolve, their resilience, and frankly, the excellence of the people that we are able to have in our healthcare system, that in these conditions, as a result of these impacts on our manpower deployment, they have been able to deliver excellent clinical outcomes. I think the uncertainty is how long do we expect them to do this for? And do they know and do we know? And there is some uncertainty with this. I think in this issue of being too conservative or do we have the right number of beds, maybe I can try to sort of phrase it the other way around. Well, first let me assume that she agrees with me that actually we can't over-divert resources from non-COVID-19 patients to stand by for COVID-19 patients that have not arrived yet. People will have heart attacks, people will have accidents, and they will need care. And if you have nurses, doctors, beds ready for only to accept COVID and not to accept all these other conditions, we will see an increased death rate. We will see excess mortality, not from COVID, but from all these other conditions. So we must increase slowly, step by step, trying to be just ahead of the curve. Ultimately, as I say, we may end up having to accept a lower standard of care, but we will want that lower standard of care, as it were, to be evenly spread across so that no part of the system breaks, that everybody is under some degree of strain and going through this together. But in terms of maybe understanding where we are, the 63% of a certain number of beds, 280 beds, it's a bit hard to grasp in terms of the proportions because we keep changing the denominator. We keep increasing the number of ICU beds. So when you had 100 ICU beds, you may have had 60% occupancy. Now we've got 280 ICU beds, you're still at 60% occupancy. So it sounds as if it's not too much of an issue. But if we try to think of it in terms of workload, so currently we have about 160 ICU beds set aside for non-COVID-19 patients. Not all of them are occupied. We'll come to that in a minute. But they are there. There's an administrative and logistical load keeping those beds on standby. We also have, by the end of this week, 280 beds set aside for COVID-19 patients in the ICUs. That's a total of about 440. So 440 beds currently set aside in both ICUs. What does that compare to in 2019? It's about 200, well, it is exactly 298, but let's say 300. So essentially, the hospital system is carrying a logistical and administrative load of about 140, 145% compared to peacetime, just on standby. But if you look at the actual number of patients that we have in the ICUs, the actual number of patients that our care teams are working on, so we have, it's about between 130 to 140 non-COVID-19 ICU patients, what we would call the business as usual patients. And today, it's 130, a few days ago it was 139. So let's say about 135, about half. That's 270 ICU patients across the hospital ecosystem that our teams have to manage. Pre-COVID-19, 2019, we had about, on average in the hospital system, 180 ICU patients across the landscape. So that's a workload increase of 150%. You can sustain that for a short period of time. Can you sustain that for a prolonged period of time? So I hope that answers the members' questions in terms of, are we being conservative or are we planning ahead? What we are hoping to do is chart a middle path, ramp up capacity just ahead of demand with enough time to give the staff some degree of orientation, training, and be ready for when the surge comes in. But not so much that we end up sacrificing the rest of our healthcare system. That would be the inappropriate thing to do. We're trying to tread a middle ground. Thank you, sir.
Mr. Jaragan.
Thank you, sir. I join the Minister and SMS in expressing my deepest gratitude to our healthcare workers for fighting this battle on the front lines and holding the fort in very trying conditions. I have two clarifications. First, based on the situation the SMS outlined, it appears the number of healthcare workers is the limiting factor for further reopening. Since healthcare human resource capacity cannot be easily ramped up and our vaccination coverage is almost maximized, what prospect then is there for further reopening anytime soon? Secondly, while the Sinovac vaccine has been added to the national vaccination program, I understand it is still not available to those who can take the mRNA vaccines. Others can register their interest but are not guaranteed a booking. So in the interest of maximizing vaccine coverage and minimizing hospitalizations, can MOH make Sinovac generally available to all those who have not been vaccinated but simply prefer to get that vaccine, whatever the merits of that preference is?
So I thank the member for his questions. I think he has misunderstood. The availability of healthcare workers is not what will decide whether we reopen or don't reopen. It is how many illnesses and how many deaths we are prepared to tolerate in that controlled process of getting to the point where, as a combination of vaccinations, boosters, and mild or asymptomatic infection, our overall population is much, much more resistant to COVID-19. Getting there is not a function of how many healthcare workers we have. How many deaths we have on the road to that destination is a function of how many healthcare workers we have and how many cases we can manage at a time. So, as I've said, and as many other people have said, this will pass, this will get better. We don't know exactly when, but we are building up our entire society's immunity and resilience against COVID-19. And as we do so, every day that passes, every extra time that we can hold the situation, we are more likely to be able to open up safely. When we do lighten restrictions, you can expect there will be more cases and there will be more waves. But if our immunity and our resilience is built up, each wave will be less threatening, there'll be less cases than the last, and hence our restrictions don't have to be anywhere near as tight. So I think, I don't know that I've answered this question directly, but I disagree with the way he's framed it, and I hope he understands the explanation that I've given. For Sinovac, I think we have to remember that the proportion of people who prefer Sinovac and who need Sinovac is very, very small. It's 1 or 2% of our total base. But also that its effectiveness with the Delta variant has not been demonstrated to the same degree as all the other vaccines. And what we're concerned about is what happens if you get the infection despite having had the vaccination. And with our national vaccination program, if you get the infection even though you've had the vaccination, having had the vaccination converts it to a mild illness. A mild illness you may not even be aware of, an asymptomatic infection, and potentially rest at home as a result. We don't have such data for Sinovac. And so, given that is the case, we feel it's our sort of clinical responsibility to recommend that if it's possible, our population take the mRNA vaccine. Sinovac is available as an option when that's not possible. So it's better than nothing, but it's not what we would see as the most appropriate, given that it is the Delta variant that is spreading through our population, and given that we are trying to avoid serious illnesses and convert this infection into a mild infection. Thank you, sir.
Mr. Ang Wei Neng.
I also want to join the rest of members here to salute the efforts put in by the healthcare workers for doing such a wonderful job so far. Meanwhile, I would like to phrase the issue of ICU beds from the other perspective. We note that one of the most important indicators, as SMS has said, that MOH is watching, is the utilization rate of the ICU beds. So I would like to clarify the following. If the utilization of the ICU beds is acceptable, that is not overly stretched, and even the daily cases are about 2,000-3,000 a day, I mean, the COVID-19 cases 2,000-3,000 a day, does it mean that we are prepared to live with this high number for the next 1-2 months? If so, are we prepared to remove some of the restriction or lessen some restriction of COVID-19? Thank you.
So I thank the member for his question. The member is correct. Mr. Ang Wei Neng is correct that the high total number, because 99% are asymptomatic, doesn't in itself mean whether we can lift or not lift. What we have to look at is the number of cases that require assistance and help from our healthcare system and make sure that we're able to provide for that. But it is not the case that only looking at the ICU utilization rate will we then make the decision. The reason is we have a much larger group of people who require oxygen. Now, not all of them require ICU care, but you can't entirely predict which of them will end up requiring ICU care. So if we have a very large base of people requiring oxygen, you have to be ready that some of them will deteriorate. And so there's a forward projection for ICU care that we have to take into account in terms of our decisions to open up or loosen or lighten. Because as the total number of patients increases, the total number of patients requiring oxygen will also increase in proportion. So it's not, he is right, but there's a little bit more nuance to the consideration. And so this is why in the previous MTF and press conference they talked about the doubling rate or the expansion rate of the ICU care. It's not the number, it's whether we think it's going up and how fast we think it's going up or coming back down again. So these are some of the factors we have to take into account, sir.
Mr. Leong Ma Wai.
Thank you, Speaker. I would like to ask the SMS whether what exactly caused the infection in our country from suddenly surge to the 1,000 cases level, I think around about the end of September. What are the various routes of infection, especially for the seniors? Because that is the base where the subsequent fatality comes about, which the SMS has shared just now. For example, there are some rumors, unconfirmed information in the public arena that a lot of these seniors have come from those who are living alone, comes from the nursing homes. And those who are infected in their own homes together with their children, how many of them are actually having another COVID patient inside the home under the home recovery program? So these various routes of infection is something that I think we hope to get more information from the SMS. Second is that while we are saying that the fatality had gone up, are there changes in our treatment protocols for the seniors in the hospital? And is there a possibility that we have some preventive treatments for seniors and also for other citizens or other residents in our country to lower the risk of COVID-19. So, in other words, are there potential treatments that we can introduce? So far, there hasn't been a lot of information on that from the government. And thirdly, of course, the most sensitive topic right now in our society is that, is there a justification to impose a vaccination differentiation on the whole group of unvaccinated people? Because the unvaccinated people consist of one, the 70,000 seniors who are still unvaccinated, and probably, like just now one of the members has raised the issue, maybe we should isolate them a bit more, or rather pay attention specially to them so that we cut down on their infection rate. But this 70,000 has come down from 200,000 in August. So maybe there is very little more leeway that we can actually convince them to get vaccinated. So we have to isolate them. And special care has been given to them, and more volunteers may be assigned to look after them and all that. So, but there's also another group of unvaccinated people in our country, 240,000 of them, between 13 years old to 59 years old, relatively healthy, but they choose not to be vaccinated for various reasons. So, but they are healthy, and they are, so is it appropriate to also impose the vaccination differentiation policy on them, especially the latest MOM advisory on which actually may affect their livelihood? Is it fair, okay, to impose something that destroys the livelihood of a person who chooses not to be vaccinated? Thank you. Sorry for the long name.
I thank Mr. Leong for his question. I would point out that his questions have some contradictions. He asked if there was a change or some treatment which could prevent COVID-19 for seniors to either get sick or get unwell. I presume that by asking that question, he then requires us to use a preventive treatment. If I propose to him that there's a preventive treatment which is 10 times effective, it would reduce your risk by 10 times, he may even then ask me to mandate it and require it. It's called vaccination. And if you're above the age of 60, it is 17 times, you are 17 times more likely to pass if you are unvaccinated than if you are vaccinated. So a vaccination answers Mr. Leong's second question. Hence, he asks then, when he then asks, how do we justify our vaccine differentiated measures, and how do we justify imposing something on people who chose not to get vaccinated? Our justification is that we are trying to save their lives. We are trying for their loved ones and their family not to lose a family member. We're trying to prevent them becoming sick and overwhelming our healthcare system so that them and the rest of us then don't lose the ability to have good care for heart disease and diabetes and cancer and all the other things that we need healthcare for. So his second and third question seem to me to contradict each other, and I think he needs to decide, does he believe that we should be fairly liberal about this and choose to allow people to take on for themselves a really unacceptable degree of risk and impose the consequences of that risk on all of us? Or does he want us to go and tell people exactly what to do and constrain their lives in a way that protects all of us? He seems to, in these two questions, choose extremes at one end or the other. We are trying to thread a middle path and try to get the best of both. He asks then what caused the infection in our country and what are the roots of infection for seniors who are living alone in their own homes. The root of infection is largely from human to human contact. And that's how people get this infection. If you were truly isolated and you were entirely living alone with no human contact, you could maybe get away without this, but I think people find that sort of life is also fairly unbearable. So whether you're living alone as a senior or a nursing home or in your own home, usually there is some form of human contact. And that is precisely why we can't think of our population as the seniors and the rest of us, the unvaccinated and the rest of us. We intermingle and we meet each other and we pass on the infection to each other. Our vaccine differentiated measures are trying to make the risk lower for one than the other, but it is not about separating us out into completely separate populations, and that would not be possible. Thank you, sir.
Dr. Sharira Abdullah.
Thank you, SMS, for your clarifications on the situation. I know that you have said that patients with underlying conditions, even if well controlled, will still be at a higher risk of death, and that not being vaccinated will put Singaporeans at an even higher risk. Could I ask if currently MOH has any data on the percentage of vaccinated patients who have died from COVID-19, who have underlying conditions that are actually well controlled? And if not, would MOH consider tracking this? Thank you.
So I thank the member for her question. It is not straightforward to answer because the definition of well-controlled will vary, and the way in which you see the impact of good control of the disease when you get COVID-19 will also be quite different. Let me give perhaps some examples. Let's just use diabetes, for example. If you have had diabetes for many years, diagnosed young, struggling with it, living with it, but you've had it kind of okay controlled, do you have a worse risk or a lower risk than someone who perhaps has had it diagnosed only 1 or 2 years ago, but really hasn't had it well controlled yet? I'm not entirely sure what the answer to that question is. And certainly when you then encounter COVID-19, even if you had it well controlled, because your body's fighting another illness, now COVID-19, your diabetes control goes out. So do you then look at well controlled at the point that you got infected or the point that you got into ICU? So the data that we have doesn't help to inform us to the point where we can make a recommendation. And we can say, well, if you have diabetes and your blood sugar is like this, you're okay, and if your blood sugar is like that, it's not okay. We are still at the point where we say, if you have diabetes, control it as best you can. Whether you have COVID-19 or not, that is a risk, but now that COVID-19 is present, you need to really make sure you take care of yourself. And this applies then to a wide variety of conditions. So it's quite clear that poorly controlled diseases do increase the risk very significantly. But there are some patients, even with well-controlled diseases, it appears that having that disease means that they handle COVID-19 poorly, even if the disease was well controlled when they get COVID-19 the first time, when they first get COVID-19. I hope that adds some clarity to the member's question. So,
Mr. Melvin Yong.
Thank you, Mr. Speaker. I thank the SMS for his comprehensive statement. I would like to shift the focus on the welfare of our healthcare professionals. I think according to the Director of Medical Services, the COVID-19 pandemic has caused a significant backlog of follow-up visits and elective operations. And it will take the hospitals many months to catch up and clear this backlog. SMS also earlier mentioned that 90% of our healthcare workers were not able to clear their annual leave. I'd like to ask which hospitals have the greatest backlog, and how will this affect the amount of leave that the staff will be allowed to take, given the immense pressure faced to clear the backlog? As there are clear challenges mentioned by the SMS to quickly increase staffing to alleviate the manpower situation, what are the hospitals planning to do to allow our healthcare professionals to at least take a break during this period?
So I don't have the data in terms of specific hospitals or clinical sites which have backlogs and which don't. Part of that is because we do operate as one system, and where there's a little bit of capacity here, a little bit of capacity there, there's some load balancing and the different sites work together. And so that is going to be dynamic. They're working to try to clear this as best they can. We are also uncertain how long this will go on for. So it's a bit hard to predict where we will be in terms of the rest of the healthcare system's duties and responsibilities once COVID-19 starts to wane, because we don't quite know when that will happen. So there is a stress on the healthcare system. It will persist for some time after COVID-19 starts to come down, precisely for the reasons the member has identified. Will this affect leave? Possibly. But the hospitals and the staff, the leadership, are going to try to find ways to give their teams some rest. And I don't think this is something that we can settle on a policy basis. It's very granular. It depends on the size of your team and the various other duties. When is your lull time? When is your uptime? And I suspect what will happen is that the different teams, the different departments and different divisions will allow rotating leave in different patterns to suit their acuity levels. And probably you may have some people who are on leave but have a relatively short notice to be present. They may be on leave, local leave, and then another proportion which are allowed overseas leave and so forth. I think these are operational parameters that you have to let the clinical teams make these decisions on their own. And we need to try and support them at a more systemic level. Thank you, sir.
Minister Ong Ikang.
Thank you, Mr. Speaker. I want to make a comment, but also to go back to two questions that were raised earlier. One is by the member, Mr. Gerald Giam, asked about Sinovac. And as SMS mentioned, it's now available as an option under our national vaccination program. So it is generally available in some clinics and also at the Raffles City Vaccination Center just nearby. So if you are 60 and above, cannot take or just don't want to take mRNA, you can walk in to take your Sinovac. Yesterday, I think a few hundred did so, covered by Zhao Bao today. And then if you are below 60, you have to make an appointment, but it's also generally available. Second point I want to mention is what Mr. Leong Man Wai raised, where he talked about some rumors. I'm not sure you can repeat rumors in this house, leave it to the leader. But he mentioned something about nursing home, something about home transmission. Nursing home infections is a small percentage of total senior infection. The last I calculated is not updated, but it's about 6.4%. So it's a small percentage. The large majority is actually transmission within the community. He asked about transmission in households. We've been tracking this, that within a household, if somebody is positive, approximately 10% of household members will subsequently get infected. So about 1 in 10. But out of that 10%, 8 percentage point get it the moment very early on. That means at the point of entry into quarantine or into HRW, you are tested and you are positive, suggesting that actually they got it at the same time as the index case. Yeah. And then during the subsequent days, another 2 percentage point then got transmitted. So therefore, I think from our evidence that we've been tracking so far, the incidence of transmitting at home, so long as you take the precautions, actually is not high. The high transmission still happens within the community through person-to-person interaction. I want to just maybe make some general comments after hearing all the questions. Dealing with COVID-19 is quite different from like business or organization planning, that you know that this season or this month coming to Christmas, business is going to go up, so let's plan for it, make sure we have the manpower, this and that. We are looking at a crisis of a generation, a global pandemic crisis. not something that we plan year to year based on season or based on 5-year plan. It hits you and it overwhelms the healthcare system all over the world. We look at the papers today of G20 meeting, and in France and in Italy, life seems to be normal, but we forgot what they went through last year. Just go back, dig up the papers last year, how the whole healthcare system was overwhelmed. Regardless of what you say about their ICU provision and all that, or their healthcare workers' provision, when COVID-19 hit those societies, totally overwhelmed. Doctors have to choose who get the bed, who doesn't, who they have to save and who doesn't get saved. And those were the painful human tragedy that happened and the big human price that they paid to get to where they are today. I think don't forget that. Mr. Lim Biao Chuan asked, how do we prevent and minimize death? We prevent and minimize death by making sure we don't go through that of what other countries have gone through. You name it, whether it's US, UK, France, Germany, Italy, they all went through that. Near home, Indonesia, Malaysia, they all went through that. We avoid excess death by avoiding that, by preventing that totally. How do we do that? By not being dogmatic. There are two camps, right, in the world. One say zero COVID strategy is the right way to go. One say, no, you got to have living with COVID strategy and maybe even Freedom Day. We say we do both. We need to do both. Last year, before we had vaccination, when we are vulnerable to the disease, we took a zero COVID strategy. Everything was tight. Borders were closed as a result. Quarantined everybody. We kept incidences very low. We kept deaths very low. And that was last year. Then we went on to national vaccination program, got ourselves to about 70-75% by National Day. And then we say, COVID zero is over, we need to start opening up. But yet, we don't take another dogmatic approach to say we must go for Freedom Day and open up all at once, but take a middle path, not total lockdown, neither is it Freedom Day, open up gradually. And what is the limiting factor? It is our healthcare system, making sure that it can cope given the infection rate and how that translates into ICU cases and to people who fall severely ill. And that is how we have been proceeding. And as SMS Janil said, with each passing day, more vaccinations and some people recovered well and build up natural immunity, we accumulate antibodies and resilience within our society. So I know members of this House, including myself, we all wish that life goes back to normal, that we can have dining in 5 or more, we can have our proper wedding dinners and events, go back to our grassroots functions and community functions. We all wish we can all do that. We don't have to sit up there anymore. Everybody sit in the chamber, engaging each other. We all wish to do that. And I think we will get there. And we get there by continuing this path, building up our antibodies day by day. I don't know how long it will take. The Prime Minister say maybe 3 months, maybe 6. We wish it's shorter than longer. But many countries have gone there, gone through the process and reached there, and we shall reach there too. Thank you.